Hi, this is Dr. Corey Hudson.
And this is Dr. Michael Antonis.
Today we're going to talk about the emergency and field side management of the spine injured athlete.
Our objectives for this lecture are to develop an understanding of the scope and acute field management of spinal injuries in athletes, understand the requirement for advanced planning related to team support personnel, EMS, equipment needs, and local resources, determine a systematic approach to the evaluation of the injured athlete with deliberate consideration of protective equipment removal on the field, and finally, recognize common acute spinal injury patterns.
Athletic spine injuries represent less than 10% of total spine injuries seen in all trauma centers. While these injuries represent a very small percentage of total cervical spine injuries overall and a very small percentage of all athletic injuries, these can be very devastating injuries to the athletes that are affected by them. The most devastating injuries are cervical spine injuries that can lead to quadriplegia, leading to significant morbidity. The highest risk athletes are American football players, and about 8 catastrophic injuries occur in this country every year, about 6 of them resulting in tetraplegia. Other high-risk sports include gymnastics, cheerleading, wrestling, and other contact and collision sports.
It is very important to develop a site-specific emergency action plan, or EAP, to delineate everyone's role on the field, as well as the availability of local resources. These resources vary by state, city, and jurisdiction. Pre-event planning also involves injury prevention strategies. A perfect example of this would be the heads-up football, where youth football is taught the correct method of tackling, where their head is up and looking at the player. Outfitting athletes with proper protective equipment, and an emergency toolkit properly stocked and readily available at the field site.
As with any emergency, it's important that when an injury occurs, there's a systematic approach to the initial evaluation. We should first begin by evaluating immediate life threats, and this includes our evaluation of A, B, C's, and D's. That's airway, breathing, circulation, and disability. Extreme caution should be taken with the routine removal of equipment on the field. Protective equipment such as helmets and shoulder pads can be left in place until the athlete arrives at the emergency department, though face masks should be removed for easy airway access. This will be discussed later in this presentation. If sideline personnel choose to remove equipment prior to transport, they should make sure that they have at least 6 to 8 trained providers ready to assist. In the unconscious athlete, respirations and a pulse check should happen immediately, and this should be followed by a jaw thrust if there is inadequate respiratory effort. A jaw thrust is preferred over a head tilt chin lift method at this time because we're trying to protect the cervical spine. The chin lift or method does cause increased movement of the cervical spine. The jaw thrust, while removing any mouth guard or other devices in the mouth, will protect the face and oropharynx and the cervical spine. At the same time, we want to try to remove any barriers to the chest if we need to do CPR. That includes opening the chest plate or the shoulder pads. This can usually be accomplished by cutting the loop straps, elastic straps, or laces after cutting through the jersey or any t-shirts in the front.
The airway operator's skill and comfort level with various techniques should guide the appropriate orotracheal intubation method. Several authors have concluded that orotracheal intubation is safe and effective when performed with inline cervical stabilization, with the one provider entirely specific to the cervical spine stabilization, while the other provider provides orotracheal intubation. Video-assisted laryngoscopy, or VAL, is a relatively newer method with various devices available on the market, and has some advantages depending on operator skill and comfort level with each of these procedures. A surgical airway should always be in the airway algorithm for difficult intubations. In order to practice surgical airway, clinicians should work with simulations and practice on tracheas, whether it be pig tracheas or simulated synthetic tracheas.
As noted previously, athletes who are wearing protective equipment that include face masks require special attention for the safe removal of the face masks. Anybody who works with athletes who use this kind of equipment should be very familiar with the type of equipment that their athletes use and the equipment that's used by other athletes and teams in their league. Football face masks are fairly easily removed, but you should still practice and be prepared to do this very rapidly should you need to access the airway of a downed athlete. Other face masks for other sports may not be so easily removed. For example, some hockey face masks, lacrosse face masks, or catcher's helmets face masks may be more challenging to remove, and in some situations it may make more sense to maintain cervical spine stabilization and remove the entire helmet in order to access the airway. You need to make this decision before an emergency occurs, not in the heat of the moment. Athletic trainers and physicians on the sideline need to be familiar not only with the helmets and the face masks, but also with the type of devices required to remove the face mask. In most cases, an electric or powered screwdriver will work with a Phillips head attachment to remove the clips that hold the face mask to the helmet. However, there are some proprietary types of face mask clips which use a spring-loaded device. These will have a specialized tool that assists in their removal. No matter what type of tool you use, it's important to have a primary, a backup, and perhaps a secondary backup method ready on the sideline, and multiple providers should have this device ready and available so that the airway can be accessed at any time should emergency occur.
Once the airway, breathing, circulation, and disability are evaluated and the athlete is alert and intact with each of these, the clinician should move onto a complaint-focused examination on the field. The exam should include assessments of pain, tenderness, strength, sensation, and reflexes. Concerning findings certainly warrant transport outside the field of play. These concerning findings include, and are not limited to, midline neck pain, bony step-offs, tenderness on palpation, weakness in extremities, or persistent numbness or tingling in the evaluation of the patient. It is important to note that serial examinations are very important to assess progression of these symptoms. Active or passive range of motion can be performed in the absence of concerning findings.
Once this focused physical exam is performed for the first time, the assessment must move to the athlete's initial positioning at the end of play, and if they have any of the concerning findings noted on the previous slide, we need to consider how we're going to move them carefully and while maintaining the best method of C-spine control to begin their transport process. If the athlete has ended up in a prone position, remember that as we log roll them while keeping the spine in a straight position, we want to have the provider who is providing the inline spine stabilization use the cross arm technique where they begin with their hands in a crossed position so that as the athlete is rolled from the prone position to the supine position, the rescuer's hands will uncross as the athlete is rolled over. If the athlete is supine or side-lying at the end of the play, we may prepare to log roll them directly into the supine position. One clinician will be at the head of the patient, and that clinician is solely responsible for manual inline stabilization of the cervical spine. This clinician should be the one who is most familiar with the athlete and should be the one who is in charge of calling all movements and all steps throughout the process. We should note that the term spinal immobilization has fallen out of favor, as it's really a misnomer. We cannot fully immobilize the spine, and it should not be our focus of extrication and transport. Our goal should be to stabilize and minimize movement of the spine as we extricate the athlete from the field of play and transport them for further evaluation and treatment. We need to consider the mechanical effects of equipment removal and the mechanical effects of any movements we make during the extrication and transport process. We want to minimize those movements as much as possible. In some cases, an athlete may be able to self-splint themselves in a semi-recumbent position on an EMS stretcher better than they would if they were strapped to a long spine board. And this is a consideration you should discuss in advance with your medical directors and your EMS transport system.
Stable versus unstable should direct the priorities of your local trauma guidelines and consideration of complete removal of the athletic protective equipment for imaging studies. The removal of the equipment should be made in conjunction on the field with all parties involved, and a decision should be made at the trauma center to either remove the equipment to get better imaging studies or to leave the equipment fully on to keep the patient splinted in the correct inline stabilization. Many centers have prioritized CT imaging involving the critical areas of the odontoid onto C1 and the C7 T1 junction with high impact cervical injuries. MRI is certainly superior for evaluating the soft tissue, spinal cord pathology, and marrow edema, and incidents when the clinical suspicion is high for spinal cord injury without radiographic abnormality on CT scan or other imaging. This is called spinal cord injury without radiographic abnormality, also SCIWORA.
The most concerning injuries, the ones that we're looking for the most, are the bony injuries and related acute fractures and dislocations that occur with concomitant soft tissue damage and the potential for catastrophic spinal cord injuries. The lower cervical spine, with its narrower diameter, is the level which is most often at risk, and the levels at which we most frequently see catastrophic spinal cord injuries in athletes. There are incidents of transient quadriplegia or tetraplegia or transient cervical cord neopraxia, which are a spectrum of injuries which often result from slight neck flexion and an axial load, which can result in brief episodes of weakness and self-limited paralysis, which occurs without radiographic abnormality. However, in the emergency setting, it's impossible to distinguish this from a more severe spinal cord injury, and the deficits noted on the field of play during transport and in the emergency department should be considered severe and significant deficits and should be considered as such until ruled out by advanced imaging.
Stingers, or also burners, as they're also known as, are very common injuries in contact and collision athletic events. These injuries are so common that nearly half of all NCAA college football players reported symptoms consistent with compression and stretch of nerve roots of the brachial plexus each and every year. Traumatic disc herniation may occur with resultant dermathermal injury patterns that should guide the clinician for urgent imaging with MRI. Local patterns of referral should also be used in consideration, as the dermatomal pattern does not always match up with the injury, and a one-time sagittal view of the entire cord sometimes can give a different location of the cord of the injured level. In conclusion, we want to make several points. Appropriate care of the athlete begins long before any athletic competition occurs.
It's very important that physicians and athletic trainers, emergency providers, and anyone involved in the care of athletes are aware of the common injury patterns, have an emergency action plan in place, and are prepared to work as a team to deliver seamless healthcare transitions from the field of play through EMS transport and into the hospital setting.
And finally, protecting the athlete against further injury, minimizing movement, and properly managing protective equipment are of paramount importance during initial management and transport to the appropriate medical center.
Thank you so much for your time. We hope you found this an educational, informative presentation.